Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Welcome to episode 81. Yes, we're live. That's right. Live from the light here in LA. We begin the last chapter of this wonderful book, chapter 34. Wow, wow. I'm so grateful and thankful for all that we have done. It's a beautiful, peaceful part of YouTube where we read books and learn from masters. I'm Master Fitness Trainer Uriel Riley. Welcome and happy Saturday. Divine Rising. Here we go. Chapter 34. Common entities in acute respiratory care. The unconscious patient. Common to all patients with loss of consciousness is the danger of inadequate airway patency, inadequate airway protective mechanisms, inadequate lung inflation, and inadequate arterial oxygenation. Thus, all acutely unconscious patients should have thorough and serial respiratory care evaluations to prevent these problems rather than to have them recognized in extremis. Upper airway obstruction is a very common phenomenon that is potentially life-threatening. Its recognition and therapy are discussed in Chapter 15. Obtundation of airway protective mechanisms may lead to aspiration, a significant threat to the survival of the unconscious patient. See Chapter 33. The airway protective reflexes are discussed in Chapter 15. The unconscious patient tends to have shallow respirations and a loss of chest wall tone. This leads to acute decreases in functional residual capacity, see Chapter 20, with eventual atelectasis and pneumonia. Appropriate assessment of ventilatory reserve, see Chapter 19, is essential in these patients in order to support ventilation and oxygenation prior to the need for resuscitation. All acutely unconscious patients demand the skills and expertise of the respiratory care practitioner. Drug overdose. He's high as heart love. I see the the heart was fluttering. High as heart love. Welcome to the peaceful part of YouTube where we read books and learn from masters. Page 499 in the middle. We are in the last chapter of this book. The overwhelming majority of intentional overdose in the United States is with sedative, hypnotic, and tranquilizing drugs. If there is no underlying terminal disease and the patient arrives in the hospital without hypoxic brain damage, survival should be better than 90%. However, mortality as high as 25% is still reported. Therefore, careful management is crucial. Numerous studies throughout the world consistently, ooh, mm, consistently intimate one obvious fact. No single form of treatment is more important to survival than appropriate airway management and cardiopulmonary support. Airway protection is the hallmark of care for these patients. Tracheal intubation is indicated when airway protection is questionable. We follow a simple principle. The patient who will allow laryngoscopic visualization should be intubated. If gastric lavage is contemplated and obtundation is present, intubations of the trachea should be accomplished. However, the benefit of gastric lavage is questionable, since at best, it may accomplish a lessened comatose period in conjunction with adequate supportive care. No evidence exists that gastric lavage decreases mortality. In fact, it appears that it may decrease morbidity in only 10% of patients. Our recommendation is that gastric lavage be carried out on patients who are fully alert and awake or already intubated. There appears to be little justification for lavage in if intubation is required only for the express purpose of gastric lavage. Once airway care is instituted, airway pressure therapy, bronchial hygiene therapy, and cardiovascular supportive therapy are applied as indicated. Extubation should be accomplished only after the patient has fulfilled the necessary criteria. See Chapter 16 for at least 2 hours. All attempts must be made to document the drugs ingested so that the CNS depressive course and other organ system toxicities may be anticipated. In our experience, fewer than 5% of overdose patients manifest hypotension or myocardial irritability when adequate ventilation, oxygenation, acid base balance, and fluid therapy are provided. Increase intracranial pressure. Prevention of brain hypoxia is the essence of acute respiratory care. Oxygenation of brain depends on maintaining adequate cerebral perfusion. Regional blood flow through the brain is a complex subject, particularly in the presence of local disease or injury. However, autoregulatory mechanisms in the brain are excellent and provide reasonably adequate regional blood flow under all but the most severe stresses. When cerebral blood flow is threatened due to increased intracranial pressure, or ICP, it is reasonable to conceive of the problem on a global basis. All right, so this is the bottom of page 500. Peace, dreaming, love, peace to all. Highest heart, love, friend. Awesome. We are in the last chapter of this book, clinical application of respiratory care. We're in the last chapter, then we will be reading a new book coming up going into the new year and after I publish my next book. So thank you so much for being here. Highest heart love. Love to all the friends and family and book lovers community here on YouTube, and love to our friends and family as well. Thank you so much. Final two reads. This is the second to last read of this book. So at the bottom of page 500, we have table 34 1. Major factors affecting cerebral blood flow. Okay. Oh, I love all the emojis. Thank you so much. Dreaming love, peace too. To all. We love you. So it says, um, cerebral for perfusion pressure, or CPP, right, equals mean arterial pressure, which is the MAP, and intracranial pressure, or ICP. One, ICP is greater than 20 millimeters Hg is harmful to brain cell survival, regardless of cerebral blood flow. And two, globally, a CPP greater than 60 millimeters Hg assures adequate cerebral blood flow. Normal MAP equals 90 millimeters Hg, 80 minus 100. Normal ICP equals less than 10 millimeters Hg. All right, 34, table 34 1. Here we go. reading this masterful book. Thank you so much for being here. Yes, we are the champions here of book reading, the book lovers community, live from the light here in LA. Oh, page 500. Look at this. All right. Moving to page 501. Thank you for the likes and subs. We're pushing towards 600 on this peaceful part of YouTube where we read books. So thank you so much for being here. On this assumption, the major relationship regarding cerebral blood flow is illustrated in Table 34.1. Thus, when one is confronted with a patient with increased intracranial pressure, it is essential to provide excellent arterial oxygenation and optimal mean arterial pressure MAP. Although pharmacologic means of decreasing ICP are available, e.g., diuretics and barbiturates, an immediate and widely used method is acute alveolar hyperventilation. Acute alveolar hyperventilation. We're at page 501 at the top. All right. Sudden increases in CSF and brain pH result in cerebral arteriolar constriction. Sudden changes in CSF and brain pH are usually secondary to sudden changes in arterial PCO2, since the CO2 will rapidly equilibrate between blood and CSF. The blood brain barrier does not allow bicarbonate ions to readily equilibrate, leaving the CSF with little buffering capacity. For this reason, the CO2 change in CSF results in a greater pH change than occurs in blood. Thus, a sudden drop in arterial PCO2 will decrease the vascular space, vasoconstriction, within the cranium and thereby tend to relieve the acutely increased intracranial pressure due to cerebral edema. This should result in an overall improvement in cerebral perfusion. Love solutions, right? And we're in the last chapter, so it's all here. We did it. We did it. Oh my goodness, this is so exhilarating. Oh my, it really is. This should result in an overall improvement in cerebral perfusion. As effective and dramatic as alveolar hyperventilation is in decreasing acute increases in ICP, it is time limited. Maintaining alveolar hyperventilation for over 24 hours will result in CSF equilibration in both pH and volume. Therefore, ICP will be returned to pre-high prevent preventilation status even if the arteriolar constriction persists. We believe that mechanical hyperventilation for purposes of decreasing intracranial pressure should be limited to short periods, definitely less than 24 hours. After the acute emergency is dealt with, ICP should be controlled by other means and eupenic ventilation restored. In our experience, this has the advantages of one, avoiding the necessity for stepwise increases in PCO2 when ventilator discontinuance is desired. Two, avoiding the metabolic acidosis resulting from a long-standing respiratory alkalosis. Three, providing an immediate decompression therapy if ICP suddenly rises during the illness. And four, providing maximal cerebral blood flow. Measurement of intracranial pressure has proved valuable in allowing diuretic and barbiturate therapy to control ICP. Under these circumstances, the ventilation should be maintained. Eupenic and airway suction accomplished only with maximal sedation. Adequate cardiovascular and pulmonary support is paramount. See section 6 and section 7. Page 502 at the top. Much investigation on brain resuscitation and brain death. Much investigation and concern have recently been devoted to the subject of brain resuscitation following hypoxic insult, head trauma, and non global CNS disease. Discussion of the present state of knowledge is not within the scope of this text. The reader is referred to recent literature for this information. Acute high spinal cord injury. With improvement in emergency evacuation systems, paramedic on the scene supportive care, and improved respiratory care capability in community hospitals, the short term survival of patients with high cervical spinal cord trauma is dramatically increasing. Although the prospect for long term survival and rehabilitation is excellent for paraplegics, the outlook for quadriplegics is far less encouraging. Nerve root constituting the phrenic nerve are mainly from C3, C4, and C5, although some fibers from C2 and C6 usually are present. Now, we're talking about the cervical spine here, okay? This is very key. Thank you so much. Oh, oh, stop and smile. Yes, we're in the last chapter. We did it. We made it. One more reading after this. Stop and smile. And we complete another book on YouTube, a medical book. Yes. Thank you so much for being here. The moderators are in the building. Highest heart love. Much love to you. Stop and smile. Live from the light. The light workers are here filling it out, right? We're just reining it in. Thank you so much. So, what I was picking out right here is when we're going through these, this is the cervical spine, okay? And this it says from the C3, the C4, and the C5. We're talking about in the neck and going into the neck. So, they're talking about from accidents. And although some fibers from C2 and C6 usually are present, cervical trauma often results in spinal cord edema and vasoconstriction, rendering the phrenic nerve inoperable for several days to several weeks. It is not uncommon for a patient with cervical trauma to present as a total quadriplegic, ventilator dependent, and regain phrenic nerve function within several weeks. And thus, initial aggressive support must be given these patients because the extent of permanent damage is not clear for several weeks post trauma. Our 5 year experience in a regional trauma center for spinal cord injury has allowed us to develop the following clinical guidelines for respiratory care of high cervical cord injury. 1. Dependence upon ventilatory assistance after the patient's neck is stabilized carries a totally dismal 2 year post hospital survival rate and essentially prevents meaningful rehabilitation. Thus, all attempts must be made to wean the patient from the ventilator. 2. In the first several months, maintenance of an adequate nutritional status is paramount. Early nasogastric feedings, gastros, gastrostomy, or intravenous hyperalimentation is essential. 3. Tracheostomy should be performed at the earliest selective time. And 4. Stabilized, spontaneously breathing quadriplegics with vital capacities of less than 10 milliliters over kg normal body weight should be maintained with a tracheal button or fenestrated tube. See Chapter 16 for the first year or until the rehabilitative process is near completion. Our experience is that these patients are severely stressed when confronted with minor infections. Without an available suction port, their incidence of acute respiratory failure, or ARF, is in the first year approaches 100%. Ooh. Mm, mm, mm. With the suction port available, the incidence of ARF, appears less than 50%. 5. Following stabilization of the acute injury, aggressive prophylactic bronchial hygiene therapy is disappointing. Incentive spirometry does as well prophylactically as aggressive chest physical therapy, CPT, aerosol, and IPPB therapy. However, these methods are very effective for therapeutic indications, e.g., atelectasis, pneumonia, and secretions. See Chapter 14. Middle of page 503. Blunt chest trauma. The thorax is commonly involved in trauma. Mhm. The patient often presents with minimal initial findings despite significant injury. Thoracic trauma is notorious for hiding life threatening pathology since symptoms are commonly insidious in onset. Often, the trauma is not recognized until cardiopulmonary collapse occurs. In addition, chest wall trauma can lead to significant pulmonary pathology several days following the traumatic episode. It is incumbent upon the respiratory care practitioner to be alert for signs of thoracic trauma and pursue clinical evaluation of these with a high index of suspicion. Chest wall splinting. Non-penetrating wounds to the thorax cause bruising and possibly rib fracture, which result in pain on movement of chest wall. In response, a reflex tightening of thoracic musculature ensues to avoid painful chest wall movement. This phenomenon is referred to as chest wall splinting. Such immobilization leads to poor ventilation of lung in the area of splinting and ultimately may result in atelectasis and pneumonia. Chest wall splinting is seldom significant in otherwise healthy patients. In such circumstances, the splinting may be partially relieved by mild analgesis. With encouragement, the patient will cough and breathe deeply to aid prevention of atelectasis. If atelectasis results of the patient experiences intolerable pain, intercostal nerve block, or thoracic epidural analgesia may be indicated to relieve the pain and allow respiratory therapy techniques to be applied. It should be remembered that uncomplicated rib fractures heal within several weeks and present no particular life-threatening problem. Don't overtreat chest wall splinting. Mm, let's keep going. Let's keep going. I was going to stop. Right? Oh my goodness. Thank you so much. Oh, Charlie James said he loves Congo drums. Thank you so much. Highest heart love. Yes. Yeah, as you can see, it's a divine, sacred place. And yes, we've been given this. So it's always to give reverence, right, to our ancestors who watch over us and guide us. And when we honor nature and we honor our ancestors and where we come from, this is a form of honoring ourselves. We don't want to dishonor any of our loved ones, any of our family and friends. So being honorable is a very, very high level quality in light workers. Thank you so much for being here and smiling with us, loving information and carrying on the righteous ways. Flail chest. Bottom of page 503. Double fracture of 3 or more adjacent ribs may result in chest wall instability that prevents subatmospheric pressures from developing in the pleural space, i.e., the chest wall will sink in, flail during inspiration. In respiratory care, the term flail chest implies an unstable area of the thoracic cage in which paradoxical chest wall movement results in the underlying lung receiving inadequate ventilation. Thus, the diagnosis of flail chest in respiratory care is made by clinical observation only. The chest x ray may document the fractures, but chest wall splinting may well lend stability to the area. The only way the diagnosis of flail chest requiring respiratory care support can be made is by observation of the unstable paradoxical chest wall. Pathophysiology. The pleural space underlying the unstable chest wall may not maintain appropriate inspiratory subatmospheric pressures, with the underlying lung becoming unventilated while perfusion continues. The resultant shunt will lead to arterial hypoxemia, which may stimulate increased ventilatory efforts. These increased efforts may result in greater flailing. Thereby, the vicious cycle of increasing atelectasis is established and perpetuated. The atelectasis eventually leads to pneumonia. When a flail chest occurs in conjunction with lung contusion, the two processes are synergistic. Although they often occur together, we shall discuss them separately. Small areas of flail will seldom prove of life threatening consequence to otherwise healthy patients. However, large areas of flailing will lead to significant morbidity and mortality. Prior to modern respiratory care, the mortality of an unilateral severe flail chest was greater than 80%. With ventilator stabilization, the survival rate is believed greater than 80%. Reported higher mortality is apparently secondary to CNS and abdominal trauma, not due to the flail chest. Secondary, right? That means it's a resulting of something that came before. It's very key. All right. I'll let you go in just a minute. Here we go. Let's complete out this page. What do you say? All right. Thank you so much, ladies and gentlemen. Highest heart love. You guys are so beautiful. Such beautiful. Angelic. However, morbidity of flail chest has not been decreased as dramatically as the mortality. This is partially due to the fact that positive pressure ventilation in a patient who has suffered chest trauma runs a high risk of causing pneumothorax. The medical judgment must be made as to whether the risk of atelectasis and pneumonia is greater than the risk of pneumothorax. Treatment. Small areas of flailing may be successfully treated with adequate pain relief and bronchial hygiene therapy to assure expansion of the underlying lung. This course of therapy requires good pain relief and a cooperative patient. Significant areas of flailing require both stabilization of the chest wall to allow bone healing and prevention of atelectasis. In our opinion, look at that. Page 505 at the top. In our opinion, controlled volume ventilation best accomplishes these goals, since, in our experience, a severe flail chest requires a minimum of 5 days of mechanical ventilation to allow adequate rib stabilization. However, other authors report good results with augmented ventilation and improper or over vigorous closed chest massage may result in sternal flailing. This seldom requires volume ventilation for stabilization and must not be criterion for routine ventilator care. Such a patient should be evaluated for ventilatory support the same as any other patient. See chapter 22. And here we go. We'll leave it right here. Pause when we continue with the last reading of clinical application of respiratory care. We will pick up page 505 in the middle. We've read over 500 pages from this medical book live here from the light on YouTube. Thank you so much to my mods in the building. I see you regulating. Hi, it's Heart Love. I wish you have a beautiful day. Fine rising. Thank you for reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, master fitness trainer, Uriel Riley. Thank you so much for being here with us. We did it. We're about to complete another book. This is absolutely wonderful. My dreams are coming true. Reading books to the loves of my life, live from the light here in LA. Thank you so much for being here. Reading with us, love to all of the book lovers community, all the authors. Yeah, we are doing it. Right? Let's have shaking it up on YouTube. Let's have a glass of love water, right? I love you so much. Glass of love water. We'll go out through our Saturday, showing and shining light, being thankful for all we have, grateful for all that we have, and all that is coming to us, because we are abundant. There's loads of greatness waiting to be unlocked. I love you. Mm. Oh, I love you. I love you. I love you. The live libation. Thank you so much. I've been right Some amazing poems, guys. And woo! Hey. You shaking it up on YouTube, reading books. I wish you have a wonderful, wonderful day and evening, and I will see you soon when we reconvene in chapter 34 for the last read of this medical, masterful healing book. Learning how to breathe, learning how to teach others how to breathe, bronchial hygiene, diaphragmatic breath. I honor you. Had an amazing year healing session the other day. We have another one coming up. Keep healing the people, right? Love to all the nurses, all the doctors, rep techs, all the OR techs, and we love you so much. Thank you so much for being the light workers of this world, helping to heal others, giving them great information like we do here in this peaceful part of YouTube, right? Stop and smile. You know it. you help the people. We honor you so much, helping to heal the people. Such a bright light. I love you. I love you. You know, I love myself. Yeah, we're doing it. Thank you so much. I will see you soon. All right? Sending love to all our friends and family. Anyone that is in need, anyone that's in pain, let them have relief. Praying for their relief, that they can just take a deep diaphragmatic breath in peace and release. You know, highest heart love. I love you. I love myself. I'll see you soon. Peace, peace.